like to thank the chairman and also the organizers for giving me this opportunity to present our work. I would like to acknowledge the collaboration of my colleagues who have worked with me to complete this work. Our work is a practical one that hopefully can be taken into the clinic when you go back to work. Those of you who treat breast cancer will know that breast cancer cells are driven by estrogen in most cases. And for this reason, tamoxifen and other compounds that reduce the levels of estrogen in the blood and in the circulation are important therapeutic interventions. One of the most important group of drugs are aromatase inhibitors. They block the enzyme that converts androgens to estrogens and thus reduce the level of circulating estrogen. And for this reason, they are very effective in the palliative and in the adjuvant setting in breast cancer women. However, because these agents are very effective in lowering circulating estrogen, there are some side effects. And it is very well known that using aromatase inhibitors can actually lower bone mineral density compared to tamoxifen. For example, anastrozole in the ATTACK study shows reduction of BMD, bone mineral density, by 6.08% and increases fracture rates from 1.9% in tamoxifen group to 2.93%. Equally, other aromatase inhibitors like exemestane and letrozole have detrimental effects on bone health. For this reason, all guidelines do recommend assessing skeletal health of postmenopausal women who are starting aromatase inhibitor and following the assessment as long as they are having the treatment, because most of these women will continue having the treatment for up to 5 years or even longer. And I have circled here the T-score. The T-score is how much standard deviations is bone mineral density compared to a younger population. And it can be measured by dual energy X-ray absorptiometry, routine DEXA scans that women use in the postmenopausal state. And hence we are in England now. I have chosen one of the guidelines, and clearly it says the rate of bone loss is accelerated by aromatase inhibitors, and these patients are at high risk of bone loss, and they should have a baseline DEXA scan to assess bone mineral density. And again, in other guidelines, it's very clear that DEXA scan and the measurement of T-score is very important primary step in assessing and following up these patients. However, do we oncologists who are trained in using cytotoxics and anti-cancer treatments, do we assess our patients for skeletal health accurately? Well, we found only two data in the literature. One was a paper in 2008, and one was an abstract recently in 2014. The 2008 paper from the United States looked at 54 patients treated between 2005 and 2006, and they found that only 40% of women who have started aromatase inhibitors have had DEXA scan requested for them or performed. And out of those women, around 50% had osteopenia and 7% had osteoporosis. And only 30% of those who had osteopenia have had targeted therapy. A bigger study presented last year in ASCO of 292 patients showed not very far away results. Only 54% of patients had a baseline DEXA scan. So we as medical oncologists are not very good at assessing skeletal health for our patients. Because we couldn't find more data, we wanted to look into our patients. So we looked at all the patients who used adjuvant hormonal therapy between 2007 and 2013. We found 554 patients. We selected those patients who are postmenopausal and on aromatase inhibitor, and we selected letrozole because most of them had letrozole. And we had 367 patients. Our primary endpoint was to see how many of these patients have had a DEXA scan within 3 months of starting aromatase inhibitor, and we have had some secondary endpoints. We found that out of 367 postmenopausal women on aromatase inhibitor, only 51% have had a baseline DEXA scan to assess skeletal health. This is very consistent with the 40 and 50% results by other colleagues. Our secondary endpoints included to check how many of these patients who have had a DEXA scan have normal BMD or osteopenia or osteoporosis, according to the WHO definition. 12% had a normal BMD, but unfortunately 56% had osteopenia and 30% or 31% had osteoporosis. Out of those who had osteopenia, 78% have received bone-modifying agents, as indicated bisphosphonates, and out of those people who have had osteoporosis, 70% have had bisphosphonates targeted therapy. Another secondary endpoint is the intervention. How many of those patients have had, we looked at T-score of -2, and the T-score of less -2 is what you can see in the recommendations. And we found that those patients who have had a T-score of less than -2, 75% have had bisphosphonates, and only 45% have had a follow-up DEXA scan. Now, obviously, we didn't enjoy these results, and we thought this can be improved. And the phase 2 of our study was a prospective study where we conducted 4 sessions to raise the awareness to the guidelines for relevant physicians. And we decided that we can treat about 20 patients over the next 5 months, and then we can reaudit the practice. So over the next 5 months, from January until May 2015, we treated 22 patients as they have started adjuvant aromatase inhibitors. And after these 4 sessions, we found that all 22 patients have had a baseline requested on the day the aromatase inhibitor was started. So the compliance was 100% compared to about 51% before this intervention. So we conclude consistently, and compared to other studies, about only half of patients have baseline screening DEXA scan, similar to other studies. About a quarter of patients who have a T-score of less than -2 do not receive bisphosphonate. In our study, we didn't examine why. There might be some good reasons. More than 0.5% of patients who have a T-score of less than -2 did not receive follow-up DEXA scans to assess their skeletal health. However, raising awareness among relevant physicians achieved an excellent compliance with these guidelines. Thank you very much.